on my
Right.
Okay. Now
Thank
it's
you.
saying minimize this, so
Yes, I
it'll
will.
block your slide.
I will. I'm going to minimize. And all right. So that's me. So welcome. Thank you so much for being here. And so I hope that I don't completely bore you to tears. I've been in the field of low vision rehabilitation for most of my career. I started out as a generalist OT in 1997. I came to this country for my first job. It was in school systems. It was actually in a very rural clinic that had the contracts for the local school systems and other types of therapy. So we did school systems. We also had an outpatient clinic and also did some home health. So I did a lot. I was exposed to a lot of different things. And one of the people that you met last week, Renee, she also came to the same clinic a couple of months later, and she became a mentor to me because I was just freshly minted out of OT school. I really didn't know a lot. I didn't feel like I knew. Well, I probably knew more than I thought that I did. I didn't have opportunities to be in a clinic and learn from other therapists because we were kind of going out to the schools, and oftentimes in the schools you're alone. You're not seeing what other therapists are doing, and you don't have opportunities for vicarious learning anyway. But Renee came along, and I think she told you her background was in a school for the blind, and so she was doing things with children with visual perception issues. It really sparked my interest, and that put me on a path to where I learned more and more about vision, visual impairments, and then got into low vision. So I've spent most of my career over there, mostly with starting off mostly with adults, and most recently I do a lot of pediatric assessments. Most of my work is just it's unusual. I consult more, and it's more of an assessment role, and I provide recommendations, but I don't see patients regularly like I would like to, and that's just because I'm so limited in my time. So just to give you a little bit of background about what is low vision. So there's a consensus in the definition, but like many definitions, there are variations. Depends who you ask. So the consensus is that it's vision. So there's some usable vision, but it can't be corrected with glasses, contact lenses, medications, or any surgery. And low vision is typically, in order to keep the definitions straight in my head, I like to think of low vision as a result, a visual result of a disease or a condition. So somebody might be born with a certain condition, a certain impairment of their vision that can result in low vision, or there could be a disease process that the end result is having low vision. The current ICD, so I don't know if you're familiar with what ICD is, but it's the World Health Organization has put together a classification system of diseases and conditions, and it's called the manual, and it's used to code diagnoses. And so low vision appears in the current ICD definitions. So it's coded. There's two different kinds of sets of codes that OTs can use, and optometrists and ophthalmologists, whoever codes low vision, they use these to define what the problem is, right? So there's a clump of codes, a set of codes, the H54 set, which relates to blindness and low vision, and it's based on the measurement of visual acuity. And then there's the H53 code set, which is loosely termed visual disturbances. And that gives some definitions for visual fields. It gets complicated. So I'm telling you this because it's not like the definition becomes slippery. So what is visual acuity and what are visual fields? So visual acuity means how sharply you can see. So when you look at something, how small and how sharp you can see whatever you're looking at. So that's a very broad definition of visual acuity. And the visual fields are how much you can see all around when you're looking straight ahead. So when your eyes are pointing straight ahead to look at something, like how much you can still see around you. So it's kind of like central vision. Visual acuity relates to central vision, and then visual fields relate to peripheral vision. So those are some, just in broad terms. And the low vision diagnoses that I just mentioned, they're based on the accurate measurements of visual acuity and visual fields. So it goes to say that as occupational therapists, because we don't learn the tools for accurately measuring visual acuity and visual field, that's what you do at the optometrist, right? Or at the ophthalmologist, where they put these lenses in front of you and go, what's better, 1 or 2? Or you have to sit in front of flashing lights and press things, or things are kind of pointed at you while you're looking straight ahead, and you got to tell if you can see it or not. So those are the tools that and techniques that are available to optometry and ophthalmology. And because of that, because they are skilled at providing those measurements, they're the ones who can diagnose low vision. So it's complicated. So this is kind of a slide to just show you how complicated it gets. Like, do you have low vision in both eyes? This is just a subset of that one set of codes. So it's low vision. Is it in the right eye? Is it in the left eye? Is it category 1, 2, 3? There's all these things that you need to know. So the visual acuity categories, for example, there's ranges of visual acuity. And if you fall within a certain range, you have either low vision or you're considered to be blind, or like legal blindness. I'm sure you've heard of legal blindness. So it's a specific category, and it has to be measured accurately in order to be thought of. And just a reminder about blindness or legal blindness, low vision means that it can't be corrected. So if you take out your contact lenses and you can't see past a certain sharpness of vision, it doesn't mean that you are legally blind without your contact lenses. Like, if your contact lenses correct your vision, or you wear your glasses and they correct your vision, then you're not considered legally blind. So I don't want to labor you with too much of the detail, but just understand that it becomes complicated. This is even more complex. The visual field is really difficult to measure. And there's so many different types of visual field measurement, but you can see over here, just from these code sets, like you can have visual field defects that are called scotomas. So that's islands of missing, like a blind spot. So right in the middle of your vision, you might not see, but you might see around it. That's called a scotoma. You can have arcuate defects. So that happens in conditions like glaucoma, where a bundle of retinal fibers get, are knocked out because of the eye disease, because of glaucoma. And so you can get an arc-shaped visual field defect, or you can have a stroke, and that can result in the processing of the visual image from the eyes to the brain. That can be, I just say knocked out, right? So that can be disrupted, and you can have an entire half of your visual field in both eyes missing. That would be a homonymous hemianopsia, for example. So it becomes very complicated to measure visual acuity and visual field, and it's not part of the training that we have as occupational therapists. One of the things that I've done throughout my career is become a low vision therapist and gain specialty certification from AOTA in low vision rehabilitation. And so I've gained a lot more knowledge and competencies, skills to perform certain assessments that are within that specialty area. So I can assess visual acuity and I can assess visual field, but only the way it presents to me. Like, I can't correct anything. I can't use lenses and stuff like that. And please feel free to stop me and ask questions. Occupational therapists aren't the only providers of low vision rehabilitation. In fact, we've kind of come into the game the last player, well, not quite last, but the most recent addition to the field of low vision rehabilitation. Within the healthcare system, we are frontline. We're the clinicians that see people who have low vision within the healthcare system. But outside of the healthcare system, there are a lot of other providers that have been around for a while. So there are professionals called low vision therapists, orientation and mobility specialists, vision rehabilitation therapists. There's teachers of students with visual impairments. Those are in the school system. There's organizations that cater to people with blindness and low vision, like there's lighthouse organizations. Several states have a lighthouse for the blind, for example, or there's state services for the blind as well. And they employ personnel that are outside of the medical field. Sometimes they're counselors or people with very limited training that become trained by the agency itself. So they receive in-house training for their role. Every state has got a school for the blind or school for children who meet whatever the state sets as the criteria for serving children with visual impairments, and often they need to be certified as legally blind. There's centers for independent living, and there's a lot of private charity organizations like the local Lions Club. We have one downstairs on the first floor. There's the Mid-South Lions, which is the regional organization, but every neighborhood, well, there's communities where there are local Lions Clubs, and they raise money for, they have specific mission to end blindness and deafness as well. So they both, for sight and hearing, they'll pay for devices. They're basically a fundraising arm to try and help people have the money to access services and devices. Incidentally, the VA, so the Department of Veterans Affairs, they have, they're like a different country. They have their own they have their own health system, which is similar to commercial health insurance or private health insurance, and similar to Medicare. And so they actually have a whole setup for people, for service members who are blind and have low vision, and they have professions specifically dedicated. They have things like inpatient rehab for people who have low vision. So if you have macular degeneration, you can go for 6 weeks of inpatient rehab at one of 6 centers around the country and spend 6 weeks just learning how to do ADLs and do woodworking and use computers. And it's kind of like, similar to what we experience in inpatient rehab in the medical field, but it's just for veterans. So it's a very unique system. So a little bit of history of low vision rehabilitation, just in general, around the 1800s, I'm sure you've heard of Louis Braille. He was or if you've heard of Braille, which is the system of, it's a tactile system of communication. Louis Braille was a teacher, and he developed the system of dots. Anyway, it was in France, but he developed there was a school for the blind, and in the late 1800s in the United States, there were several private schools that were specifically for blind children. There were schools for the blind, and that raised awareness of the issues surrounding people who were blind. They could still learn. So like before that, blindness was thought of as a punishment by God, and a lot of people didn't think that people who were blind could be educated, but that changed in the early 1900s. There was a recognition that it's not binary. It's not like you either have sight or are completely blind. There's somewhere in between, and that was the beginnings of the understanding of low vision. So low vision doesn't, like, it's a spectrum. There's a spectrum of sight. Up until then, children who had some sight, who were partially sighted, were actually educated in blindfold. So they were blindfolded and they were taught not to use their sight. Something similar happened with children who were hard of hearing as well, with the deaf community. Like there was a movement against learning like lip reading and stuff like that. But I don't know a lot about hearing, but about sight. So there was a recognition of partial sight. In the 1930s, there were social security protections that were legislated for people who were blind. So there was like a recognition that there should be tax exemptions because being blind, makes people require more resources or different types of work conditions. And that's where the term legal blindness also came about and was developed. It was like we have to have some kind of standard or criteria to determine whether you're blind or not. So that's how legal blindness came about. And then in the 1940s, after World War II, veterans were returning home with a lot of injuries and blindness, partial blindness. And so the VA started rehabilitation programs for blinded vets. And so professions started to arise, especially orientation mobility, which is the profession that teaches people how to get around safely with a long cane. That was one of the professions that was born out of the need to help blinded veterans in the 1940s. And so more professions developed. And then in the 1980s, there were assessments and tools that were developed, and more low vision devices came about, and electronics, and things started to kind of bloom for the low vision industry. In terms of occupational therapy, so before about 2000, so that's about when I started my career. Before then, there weren't many services for people with low vision and blindness. What happened in the late 1990s was that physicians started to really understand, like, we need help, these people need help. And ophthalmology lobbied Medicare and said, you need to provide rehab dollars for people who have low vision. And that's where OT entered into the picture, because in 2002, Medicare put out a memorandum and said, people with low vision deserve rehabilitation by an occupational therapist. And there's money, there's funding. We will pay for rehab by an occupational, they specified OT. They actually also specified PT, but PT didn't get into the game as much as OT did. And so there was money available, funding available, and it just opened the floodgate for OTs to really get into this profession. And by 2004, AOTA did some investigating, and between 2004 and 2006, a specialty certification in low vision was developed for occupational therapists and OT assistants. And guess who was on that panel? I did some volunteering at that. It was a very exciting time. I worked, there were 5 of us on a committee for AOTA, and we developed this kind of the standards and the criteria. So like your PDEs and your APDs, your professional development, you've got these outcomes with criteria. So it was it was a similar process with a portfolio where there was certain knowledge that you had, that a specialist would have to demonstrate, and certain skills to demonstrate. It was very exciting. Also in the late 1990s, this was published, it's called the hierarchical model for evaluation and treatment of visual perceptual dysfunction in adult acquired brain injury. And this was developed by one of the pioneers in low vision by the name of Mary Warren. Dr. Warren was very, very active in the field of low vision. I think she retired about 2 years ago, but very active, very prolific, and very productive. But she worked with clients who had head injury, and what she basically kind of came to this understanding that there are certain foundations of vision. There's these primary visual skills, and without them, if they're not in place, then then we cannot interact with the environment. And so this is a model basically saying that all the higher perceptual processes and being able to interact with the environment through vision require a solid foundation of having sharp vision, so visual acuity, having full visual fields, and having normal ocular motor control. And there were some papers, there was an early paper that said that one of the issues that OTs were having was that OTs were assessing visual perceptual skills without understanding the foundations of vision. So it's like, if you find perceptual problems, you got to dig deeper than just form constancy and spatial relations and things like that. You actually have to start at the foundation and see, does the child have good visual acuity or good, can the problem be explained by the basics of like the foundations of vision? And a lot of that was being missed. So, and I'll teach more about this hierarchy of visual perception in later courses. I don't want to really delve into that right now, but it's important for us, for me to tell you what I don't do and what I do. So low vision rehabilitation isn't like, I don't work on visual perceptual deficits. It all comes down to visual acuity and visual field. I definitely don't work on eye movement disorders, and I'm going to come back to that point. Lazy eye or amblyopia, visual neglect, like it's not low vision rehabilitation. It's not monocular vision. Like if somebody just has one eye and has one good eye, that doesn't meet the definition of low vision. I don't do vision therapy, and so that's oftentimes I'm going to talk about that as well. If people have double vision, so low vision rehabilitation doesn't address double vision, doesn't address the inability to track. It's not about dyslexia, presbyopia, which is age-related loss of ability to read. Like this is presbyopia. That's why I need reading glasses. And it's not about reduced depth perception. So those don't really meet the classic definitions of low vision rehabilitation. I have in the past worked with people and still do people with age-related macular degeneration. So that causes central blind spots in a person's vision. They have blurry vision. People with glaucoma have reduced visual fields. Diabetic retinopathy, they have scattered vision loss. People who have inoperable cataracts, and sometimes after cataracts, they can result in low vision. There's hereditary retinal disease, optic neuropathy, other diseases of the optic nerve, people who have strokes. So there's a lot that I do work, a lot of people with conditions that I do work with in low vision rehabilitation. But low vision rehabilitation is not synonymous with vision therapy. And I think that's where a lot of the confusion has happened. And when I first went to the Southern College of Optometry to introduce myself, when I first came to Memphis around about 2004, I went to a meeting and I was the person at the time who was the chief of low vision services didn't want to shake my hand. She said, I don't like occupational therapists. So that was how I got, that was interesting. So, but there has been historically, and I have to say this, there has been a lot of misunderstanding of the role of occupational therapy because we just came on the scene so fast and just like we were right there, and we really have a lot of skills. And I think a lot of the other professions that had been established in the private sector and in the non-medical sector became very worried about job security. Rightly so, I think. So what do I do in low vision rehabilitation? I'll train patients to use their devices, work with lighting, modify the environment, environment, modified tasks, and I'm going to give you a little bit more information about that, but I do not do eye exercises with patients. I don't do anything that's related to eye exercises. I don't prescribe optical devices. I don't prescribe glasses, and I don't do visual perceptual exercises. So those are some of the misconceptions about low vision rehabilitation. And in fact, I said I'll come back to this. Dr. Warren, who is, really the pioneer of low vision rehabilitation and occupational therapy. She worked both in low vision rehabilitation and with patients specifically with brain injury. And she wrote a couple of papers. One, I just put the title over here. It's The Argument Against Providing Vision Therapy and for Focusing on an Occupation-Based Approach for Clients with Oculomotor Impairments from Acquired Brain Injuries. So that's where sometimes there's a slippery slope, like when OTs start to do things that relate to eye movement control, that has been a big issue. Like, that is not our scope of practice. And she outlines very well the argument for why OTs need to stay clear and steer clear of vision therapy. And there's a very good reason for that. Another reason why we need to stay clear of that is because we use theories, right? So occupational therapy theory is supremely important, and theory helps us answer the question, why does OT work? Okay, so I originally on this slide had the word, instead of magic, I had the word medicine. And it's like, what is the medicine that makes the person feel better? So like, what is our OT medicine? And my mentor said to me, I don't like the word medicine, because I was discussing it with her. So I thought, okay, what is the magic? So like, what is it that we do? What do we believe about our profession that we do that makes a person healthy, that makes them feel better, right? And what is it? You tell me. What is that? Like, what do we do with patients? It's occupation, right? It's in being able to do stuff that we want to do, right? So that's the medicine. Do you get that? So the way that we view health is when somebody can be engaged and occupied. That's the magic that we use. We set things up. We work with the client so that they're able to engage in their daily occupations. And how do we know if it's working? Because we have outcomes, right? We use assessments and we look at outcomes that are relevant to our client. So we have theories, and there's a bunch of them that tell us why occupational therapy works. Yeah? You with me? I know this is a difficult slide, but it really distinguishes us from other professions, because what we do looks like what other professions do. Like sometimes a rehab tech might be doing something that looks like what occupational therapists do. But what distinguishes us is that we have a theory, and we can analyze, we can understand why we provide certain interventions. Because of we build it on theory, and we can prove that what we do will lead to the outcomes that we desire. That distinguishes us as professions from just technicians. And other providers, for example, vision rehabilitation therapists or orientation mobility therapists, low vision therapists, they don't have models of practice. They don't have theories that they can say, this is why our interventions work. Because our interventions do look the same. But we have OT theory and science behind this. So I'm going to tell you a little bit about how I use like the model that I hang my low vision rehabilitation on. And that's the PEO model, the person, environment, occupation model. And so this model came about in the mid-90s by some Canadian occupational therapists, and they said that the person includes the physical, cognitive, spiritual. They didn't use the language of OTPF, but you can use the language of OTPF to define what the person is. So it includes the physical, cognitive, spiritual aspects, as well as attitudes and preferences. So we look at what's going on with the patient. Then there's the environment. So environments are specific to the occupations for this client, and they're going to be influenced by the person, like by their personal taste, by the layout of furniture. So what the environments are, and environments can also be the physical environment, the cultural, the social, the economic environment as well. And then we've got the occupations. And so according to the occupations, according to the authors, the occupations include self-care, productivity, and leisure. So very similar to the OTPF. And I remember this was written before the OTPF, and the OTPF has also evolved in its own language. So this was pre-OTPF language. And so the occupation, looking at what occupational choices the person is making. And in the middle, we've got the results. So occupational performance is the result of the overlap of all these three constructs. And the fit between the person, the environment, and the occupation is dynamic, and it changes over time. And the better the fit, the better the occupational performance. So if there's a better fit between the person, the environment, and the occupation, they're going to have better, more meaningful participation in occupations. So let's see them fitting together and growing. This thing's going to go big. Yeah, better fit. All right, a star is born. So I'm going to tell you about some occupational therapy interventions using the PEO. So let's look at the person, the environment, and the occupation. I'm not going through everything. This is the way that I have categorized the way that I do low vision rehabilitation. I can look at the person, can make them aware of, so these are interventions specific for the person, awareness of their missing visual field, if they have a blind spot, retraining, fixation and scanning. So these are very specific skills related to low vision, and being a specialist, I have the competency to do this kind of retraining. I can teach them skills to use devices, encourage self-advocacy, and improve their health literacy. So just like things like knowing how to say the name of the eye condition that you have. It's happened so many times where a patient will tell me that they have macular degeneration. And so if a patient can't say the word, then how are they going to look up the information? Like, how can they educate themselves if they don't even have the right words? So those are some of the types of things that I'll do for the environment. So matching the light to the tasks is really important. Eliminating glare sources, using contrast, reducing pattern and visual clutter, organizing environments, resizing objects, educating caregivers, and encouraging social support. Those are some of the things that relate to the environment and the context. And then looking specifically at occupation. So matching the optical devices to the person and the task. So different devices have different features. It's like any kind of technology, it's got to match the person's ability to use and match the task. Sometimes compensating using other sensors, simplifying tasks, repositioning, using other ADL objects, addressing routines, and then facilitating well-being and promoting safety. So these are just like in general, just broad categories of interventions. So over here, I'll show you an example of, here's an example of a patient who has a central blind spot, and helping her to become more aware of where that blind spot is. So this is a specific technique that I've used, and it's this very short video. So the patient has trouble seeing with sharpness of vision. And so I'm telling her to look towards where the tip of the black arrow might be. And at the same time, she's holding she's holding something in her hand and moving it around to see where it disappears and where it reappears. So it's kind of like actively training her to know where the blind spot is, because so one of the things we know about the brain, it will fill in information. For example, if you close one eye, we actually have a blind spot. We have a blind spot. It's a physiological blind spot where where the optic nerve kind of becomes a bundle like the ponytail and goes to the brain. But you guys can't see it. Can you see where your blind spot is? You can't see it. I know you can't see it. I have to do something and I have to show you how to do it, but I'm not going to do that now. But we have we have a blind spot. So if somebody has macular degeneration, they may not even know and be able to articulate where that is. So this is just a quick little video of what the person is doing. This is a little technique.
Right there, seems like.
Sorry
Let's
about
get
that.
it real good and clear.
There's probably the best
Great.
as far as seeing the.
Good, good. So she was looking to find an area of clearest vision while she's looking at the tip of the arrow. It's a technique called eccentric viewing. It's a special technique. Another thing would be teaching skills to use the device. So here is a type of device. It's an electronic magnifier. It's very powerful. It's got a lot of capability, but using it can really be difficult for some people. So over here, what it is, it's a video camera and it's mounted to a screen and there's a flat table. And if a person doesn't know how to move that table along properly, they can kind of cause themselves to have a lot of nausea. And so over here, this is just like an activity where the patient had to follow along, like keep that, I just taped a coin to the monitor, like a little something that she had to keep moving the tray just to kind of get a sense of how to maneuver the device. But teaching patients to use their devices is important because otherwise they just end up in a drawer or in a box. Here's some ideas for interventions for the environment. So matching light to task. So this is on the left. I love this story. I had a patient who had a closet full of clothing, no light in the closet. So I took a dog leash and a little $1 flashlight and attached the flashlight on a leash to the clothes rod. And she was like, wow, this is blue. I always thought it was black, so having good lighting and learning how to use the light. So sometimes the things are really simple, but they're not simple if you didn't know it or if your neighbor couldn't tell you. So on the bottom over here is just using a high contrast, just skinny little yellow, like stationery labels, and I cut them into little strips just to make a grid, like a tic-tac-toe around the numerals of the microwave so that the patient could then actually figure out where the numbers were, because without them, it was just all like a gray blob. And so that helped her. So that's another way that we can, we're modifying the environment. Organizing. So on the left is a picture of a patient's closet. She'd broken her hip in the closet. She had macular degeneration. She broke her hip in the closet because it was so unorganized. She couldn't manage it. So we looked at lighting and organization. On the right, I was actually working with a caregiver. So educating caregivers is also very important because often people with low vision, they can still see, but they can't. They can see, but there's a lot of tasks that they can't perform, and caregivers become very suspicious that they're malingering or they somehow, they can do stuff that they really can't. So educating caregivers on what it might be like. Actually, my doctorate was a program in which I educated caregivers using simulators, and I had a whole educational approach, but it was very impactful when caregivers can understand what the person actually does see. Occupation. So like I said, we want to match the device to the person and the task, use other senses. So over here, we've got an example of a patient using a little electronic magnifier, because a regular magnifier didn't provide as much high contrast as an electronic one could. In the middle is a picture of a patient using a guide, like a stencil guide for writing a check. And the one on the left is a recent picture of a patient who I thought she was ingenious. She came into my clinic, and these are pictures taken with permission, just by the way. And she used a wooden broom handle. So it was like she was rowing a gondola. And I thought it was great because it was a combination of a long white cane, but a long white cane is very lightweight. It's not used for support. And then, so it was a combo of having a very long cane, but one that she could bear weight with. I thought that was really fantastic. And then on the right was a patient who had low vision, but we were talking about exercise and the importance of, being able to exercise, and she was showing off. Just the kind of granny that I'd like to have. So these are just a little bit of ideas. The approaches, so just to go back to the OTPF, so we can work on establishing, for example, establishing skills to use devices. That is very important, because just because you give somebody a device, some of the students over here helped with St. Jude, the workshop. I mean, what did you think about using devices? Like, you needed a little bit of training, right? As smart as you are, it's like not really something that you can just buy out of a catalog and figure out, even though it seems like it would be that way. There are skills that one needs. So establishing skills, modifying, for example, modifying the light for reading, adding light, that is a type of a modification, or an approach. Preventing falls, so teaching sighted guide, which is a way of guiding a patient who's blind. Like, often we see people, the elderly especially, like, we want to give them, we want to honor them and respect them and ask them to go first. And if you do that with somebody with low vision, it's like the blind leading the sighted. It should be the other way around. So there's a technique for guiding somebody who has low vision, and other things that related to preventing falls, but which I won't go into right now. Okay, so just in general, so here, like, if I take the PEO and look at all the things that we do, and look at where optometry and ophthalmology, like what they do, so they are really important in providing the right lens, so the right correction. But even with designing the lens, like, sometimes I've had to educate the optometrist and ophthalmologist, like, don't put your patient in bifocals, because that divides the seeing area into two different focal distances, and that can actually lead to more falls. So that needs collaboration. Glare reduction and enhancing contrast. So there's certain filters, certain shades that a patient can wear that will help to reduce glare and help with contrast. So that's something that an optometrist or ophthalmologist can do in their clinic. And then the ophthalmologist or optometrist, based on the visual acuity measurement and visual field measurement, can decide, well, do things need to be enlarged or reduced? Because not everything needs to be enlarged. If somebody's got a constricted visual field, we don't want to make things bigger, because that can make it worse. And then sometimes the devices are matched to the person and the task, but we still need to be collaborating over there, because sometimes the devices aren't matched to the task, because activity analysis is not really, it's in our wheelhouse, let me put it that way. Okay, so let's talk a little bit about oculomotor dysfunction. This is my last slide. Whatever I've told you up until now has really been a focus in low vision rehabilitation. Has been focused on interventions that address visual acuity loss and visual field loss, but nothing related to oculomotor dysfunction. So what about that? Because, should we be doing eye exercises with patients? So there is an argument that we really shouldn't. It's not something that we learn about extensively. It's not within our scope of practice. And in fact, in several states, optometry has limited the scope of practice of occupational therapy because of this issue of eye exercises. However, in brain injury, we see a lot of oculomotor dysfunction. And because we are frontline clinicians, like we're in acute care, we're in inpatient, we see, or in outpatient clinics, like we see this problem. We're the first to observe the oculomotor dysfunction paired with occupational performance. Not every optometrist can go to a hospital and see patients. So there's optometrists are, they're classified as physicians by Medicare, but only for the purpose of low vision rehabilitation, like supervising a plan of care for low vision rehabilitation. But otherwise, they're actually considered at like OTs are, or physical therapists. They have a doctoral degree, but they're actually clinicians at the same level as OT and PT. So can they refer to us for eye exercises? Well, that would be like a PT referring to us for lower extremity exercises. Like, could we do it? Maybe, but we have a choice. Probably have to look at your state act and state practice act. So it's very, you definitely have, every state regards the ability of optometrists to make referrals to OT differently. It's different state to state. So the main point is we should be focused on occupations. It's not to say that we don't use our eyes during occupations. We absolutely do, but we have to stay focused on occupations, use our theory. And another thing with with brain injury is that a lot of the interventions that I just described to you, a lot of them do work. So limiting the amount of light, like wearing sunglasses, using high contrast. We didn't really talk about addressing routines, simplifying. There's a lot of our wheelhouse type of interventions that also work for brain injury to reduce visual stress. So we still want to enable patients to do occupations. We need to stay focused on occupations, and collaboration, of course, is going to be key with our eye doctor counterparts. So that's all I have. Thank you so much. I feel so popular. Thank you for being here. And these are my references. And if you have any questions, I'll be glad to answer them. I'm going to see if, let's see. I'm going to stop sharing and open up the chat. I see there's a chat question. I hope it wasn't right at the beginning. Oh, it just says thank you. Okay. Guys, I know you're tired. A lot of you have been here since like 7:45 or 7:30. Yes. Certification. So I became a low vision therapist, and I've got specialty certification in low vision. As a low vision therapist, which is a different certification, it's like outside of OT, that was a 350 hours supervised, but by remote supervision, like an internship. I had to be working with patients, and I had a supervisor, a mentor who mentored me, and then I had to sit an exam. And then for the SCLV, well, I kind of got it like as being part of the founding member of the certification, which incidentally, as of this year, has gone away. So I don't know where that is, but there've been a lot of changes over the years. Who else wants to take a stab at me? Yes, ma'am.
For an OT student who's finishing the program, maybe even finishing level 2 field work, what's a way that they can get?
Oh, I love that question. So I would, if you want to, so there's a couple of things. I'm always happy to connect you to have an opportunity to watch eye surgery. I learned so much from eye surgery, or even just going to an eye clinic and shadowing and just getting familiar with the terminology, like where are the eyeballs and what's in them. That's important. Then the other thing is, if you want to do any continuing education courses, because you'll be doing them like for the rest of your life, you'll be doing continuing education courses. I would look for courses that focus on low vision rehabilitation and understanding those foundational skills of visual acuity and visual field. I would stay away from the from things that are visual perception and oculomotor based, simply because the oculomotor based, I mean, it's okay to have it. It's important to have an understanding of that, but it kind of veers into vision therapy, which is not in our wheelhouse. It's really not, like, we have no business going there. But definitely do take courses about like macular degeneration and glaucoma and dealing with age-related eye diseases and low vision rehabilitation, because those will give you really solid foundations in low vision. Great question. So the patients at Hamilton Eye come from the physicians at Hamilton Eye, so the eye doctors, but also from the community. So I've kind of been well known in the community. Some of the doctors have retired, so I don't get as many referrals. And because my availability of clinic has been reduced a lot, so I don't get as many referrals. But it's still, I mean, I'm booked out like 6 months in advance. And I'm ready to download my brain to any student who just you show a slight bit of interest, I'll be like on you like a mosquito. Yeah. Mm-hmm. Mm. Anybody else? I don't want to keep you. I don't want to drag it out. Yes. Great question. So the question was, how do, like, devices, does insurance pay for them? Nope, they won't pay for your teeth. They won't pay for your hearing aids. They won't pay for your glasses. They won't pay for devices. There've been a couple of bills in Congress that have been introduced to get that changed, but have failed. I'm just waiting for a couple of senators to get macular degeneration. And not have the health care that is provided by, yeah, I'm just waiting for it. That's what it's going to take. Yeah. Good question. Yeah. And some of them to like lose their teeth and become hard of hearing and be poor. I want the senators to be poor. Representation matters. Yeah. Good question though. All right, guys, we're done. Thank you so much for staying. I appreciate it.